A 70-year-old man presents to the emergency department with a sudden loss of vision in his right eye. The vision loss occurred over a few minutes, and he describes it as a curtain descending over his vision. He has a history of hypertension, hyperlipidemia, and atherosclerosis. He also reports occasional jaw pain and tenderness over his temporal arteries. On examination, his visual acuity is reduced to hand motions in the right eye, and a relative afferent pupillary defect is noted. Fundoscopy reveals a pale retina with a cherry red spot at the fovea. There is also evidence of arterial narrowing. What is the most likely diagnosis, and what is the underlying cause of the condition? A. Retinal vein occlusion, occlusion of the retinal vein due to hypertension. B. Central retinal artery occlusion, embolism from carotid artery atherosclerosis or cardiogenic source. C. Giant cell arteritis, inflammation of the temporal arteries leading to vision loss. D. Diabetic retinopathy, chronic hyperglycemia leading to retinal vessel damage and hemorrhages. E. Age-related macular degeneration, degeneration of the macula due to aging and genetic factors. Correct answer, B. Central retinal artery occlusion, embolism from carotid artery atherosclerosis or cardiogenic source. Explanation 1. Central retinal artery occlusion. Pathophysiology. CRAO is caused by blockage of the central retinal artery, typically due to an embolism originating from the carotid artery, or, less commonly, a cardiogenic embolus. The blockage leads to ischemia of the retina, resulting in sudden, painless loss of vision in the affected eye. Fundoscopic findings. Classic signs of CRAO on fundoscopy include a pale retina due to ischemia, a cherry red spot at the fovea caused by the contrasting color of the macula, which is less affected by ischemia, and arterial narrowing. Risk factors. The most common causes are carotid artery atherosclerosis and cardiac emboli. Less commonly, CRAO can be associated with giant cell arteritis, GCA, which can cause inflammation of the temporal arteries and lead to occlusion of the retinal arteries. 2. Why not other options? A. Retinal vein occlusion, RVO. RVO causes vision loss due to blockage of the retinal vein rather than the retinal artery. RVO is associated with hypertension, diabetes, and glaucoma, but it presents with retinal hemorrhages, edema, and dilated veins on fundoscopy, not the pale retina and cherry red spot seen in CRAO. C. Giant cell arteritis, GCA. GCA can lead to retinal artery occlusion, causing CRAO, but it is less common than embolic causes. GCA typically presents with headache, jaw claudication, and temporal artery tenderness, which can point to the diagnosis when these symptoms are present. If suspected, GCA requires urgent treatment with steroids to prevent further vision loss and systemic complications. Diabetic retinopathy. Diabetic retinopathy is due to chronic hyperglycemia causing microvascular changes, microaneurysms, hemorrhages, and neovascularization, but it does not present acutely with sudden vision loss and the characteristic findings of pale retina and cherry red spot. E. Age-related macular degeneration, AMD. AMD leads to gradual central vision loss, typically presenting with drusen and macular changes, but it does not cause sudden, painless vision loss or the cherry red spot associated with retinal artery occlusion. Key takeaways for USMLE. Central retinal artery occlusion, CRO, is a sudden, painless vision loss caused by an embolism in the central retinal artery, often from carotid artery atherosclerosis or cardiac emboli. Classic findings include a pale retina, cherry red spot, and arterial narrowing on fundoscopy. Giant cell arteritis can also cause CRAO, and it requires immediate treatment with steroids. Retinal vein occlusion and diabetic retinopathy present differently, with venous dilation, hemorrhages, and exudates, rather than the pale retina seen in CRAO. Would you like to dive deeper into the